visual field or gets a visual field in their testing. This is a test that most patients hate. We have a direct correlation when we tell the patient that next time you come, we will be doing a visual field, and them not coming for the appointment. They hate it so much. We hate it because it is very subjective. The technicians hate it because they have to sit there and do this test, even though it is just a 3-minute test in most cases. They hate it because it's in a dark room, they have to watch the patient, and so on and so forth. That's why we want to get away from it. And that's why we have now transitioned actually to the virtual reality headset. I don't know if you have it here. Okay, but this is basically like a Apple Vision Pro that you put on your head, and it gives you a game. And you keep both eyes open, and you keep your glasses on, and you sit where you're sitting. You don't have to go to a dark room. And you mash the buzzer in your hand that whenever the rocket crashes an asteroid or something like that. It's a game. And we use it for pediatric patients. And I found that it was very helpful for my patients as well. Whenever I did the study of who likes the regular visual field, who likes this virtual reality, 99% said virtual reality. They want to do that one because it's a game. They can keep it open, both eyes. The biggest advantage was patients with -10 myopia. So I had a -10 myope patient, just to give you an example, who was being worked up for retinitis pigmentosa. Guess why? She had no evidence of retinitis pigmentosa. Because every time she did a visual field, it was very dark on the outside. Because they didn't have the lens that would correct her refractive error. And she had this unnecessary diagnosis for which she was worried. She was worried about her future life and everything. And we did the virtual reality test, and it was completely normal because we had to let her keep her glasses on. So it would have been nice if she was a contact lens wearer. We would have avoided that, but she wasn't. So anyway, just giving you an example of this virtual reality which is coming. There are many companies that are also involved in doing online visual field tests, and I tried one, and I gave it up in 30 seconds. There is, first of all, no incentive. Why would a patient sit at home, put on a computer, and torture oneself? Come on, no, there is no incentive. The patient is not going to do it. So the way to do it is virtual reality in the office. You must remember it is a completely subjective test. And you have to tell the patients, there are a few things I teach every new visual field technician. You tell the patient that this test is going to detect the level at which you are going to detect the stimulus, detect light. So half the spots will be below your vision. You won't be able to detect it. So there will be periods of silence. And don't get worried, because it is actually trying to determine when you can see the light brightness. Second is, whenever you think you saw the light, you press the buzzer. And 2, the machine is going to try to fool you, so don't try to mash the buzzer when you hear the sound. So once you prepare the technician for these instructions to be given to the patient, then the performance of the visual field improves. Now, CETA fast, CETA standard, I guess you have Humphrey, right? Yeah, most of it. Humphrey is the most commonly used machine. So when I started my fellowship, it was always CETA standard for everybody. CETA standard was the standard. If you did anything different, you were not following guidelines. The problem was, after 5-7 years, my patients got older and they couldn't perform the 5 minutes of the CETA standard. So I had to convert them to CETA fast. And then I felt, this is a longitudinal lifetime disease. There is no point changing halfway. Why not start with Sita Fast? So I now always do Sita Fast for all my patients because it improves the reliability. I know it's not as sensitive as the Sita standard, but it's much more reliable. The other thing is that the Sita Fast is only 3.5 minutes, and Sita standard is about 5 minutes. So some other glaucoma doctors are saying, come on, why? It's just 1 minute more, right? 1.5 minutes more. Why don't you do a Sita standard? The value of 1 minute actually depends on which side of the bathroom door you are standing. If you're outside the bathroom door, that 1 minute is 10 minutes, right? So that is the value of that 1 minute. That 1 minute extra causes the patient to lose it. And the patient will just press the buzzer, and the whole test becomes unreliable. There is also another machine that is called the Compass. I don't know if you have that here. It's a device made by the company that makes eye care. It's an IDEC device that is now owned by them. It's a device that, it's a fundus camera. And the patient sits there in a lighted room, and the stimuli are placed on the retina. And you can see where the stimuli is being placed on their fundus. And the patient mashes the buzzer. If the patient moves, because the machine tracks the blood vessels, the whole visual field moves. So there is no fixation error, because now the patient is moving with, the machine is moving with the patient. I also do not do visual field testing on my patients until I have met them, until I've seen them in person. Nobody should undergo a visual field until I saw the patient. They can undergo OCT before I see the patient, but not visual fields. Why? Because they'll hate me from the start. This doctor makes me do this punishment. And they've been calling it all sorts of names. Oh, it's like that toilet bowl. No, you put your head there and you suffer. And that's not the main reason. The main reason is I want to see how this patient enters my room, how this patient sits down on the chair. When I shake their hands, are they able to reach? If I put out my hand and they are not able to shake my hand because they didn't see my hand in the lower half of their visual field, they may need a 10-2. Why do a 24-2 if they've got only a central island? Also, what is the speed at which they shake my hand? What is the reflex? If the reflex is very slow because they got Parkinson's or they're old or arthritic, they're not going to mash the buzzer in time. There is no point doing the visual field, because once you have a visual field result, you are unfortunately obliged to act on it or disprove it. So if you've got a black visual field, you have to disprove it or act on it. So it is better not to get those tests done in such patients. Okay, broad overview. Let's begin. Learn from my mistakes. Yeah, I have no disclosures. Learn from my mistakes. You should have connections. Anyway, just like this stop sign, look out. Birth date and current date. If the year of birth is incorrect, entered by the technician, you are going to get an incorrect visual field because it is an age-related database. So current date also is important. Thankfully, the machines put in the current date, but the birth year has to be put in correctly. Refraction, up to date. This is the biggest problem, refraction. Why? Because many technicians and the machines, not just them, the machine also does not calculate for an ad if the patient is below a certain age. If the patient is 30 and is pseudophakic, it will say, oh, plano for distance, perfect, no need for ad. because it doesn't realize that the patient has turned pseudophakic. So if you do cataract surgery for anybody below the age of 50, patient is pseudophakic, aphakic, please let the technician know that this patient is pseudophakic. Put in the correct ad. Color of the stimulus. This machine, unfortunately, has a memory. If somebody did a red stimulus visual field for plaquenil toxicity, the machine remembers that for the whole day. Everyone after that patient will get a red stimulus unless you put off the machine and put on the machine again. So that is a problem. Of course, stimulus size is important. Patients who are getting stimulus 5 visual field 10-2, suddenly the next time you'll see a very constricted field. And the reason is they forgot to put stimulus 5 and they put stimulus 3, which is the default. And then, of course, the visual field is constricted. And my fellow is saying, no, we should do trabeculectomy because the patient's visual field is down. It's like, look at the stimulus. The stimulus is different. We talked about reflex time. PSC, posterior subcapsular cataract, and dense PCO, posterior capsulopacification, are things that actually depress the visual field significantly. It makes the scotomas that exist become darker. Eyelid or hair. This I used to not pay attention to at all until last year. I had 3 patients back to back that had dense superior arcuate scotomas. And I looked at their OCT and the OCT was normal. I was like, how can that be? I repeated it, it was the same. And I'll share that with you. Fixation losses. Sometimes the machine is not able to find the blind spot, so it will say 12 out of 12 fixation losses, even though the patient was fixating properly. But there are some machines, you will realize some new software which is CETA Faster. Do you use that here? CETA Faster? No. Good. Because it doesn't test fixation in most cases. So the fixation is always 0 upon 0. So you don't know whether the patient looked straight, did not look straight, what? False positive, false negatives, what is reliable? Fixation losses. So false positive and false negatives under 25% is considered reasonably reliable. Fixation losses under 33% is considered reasonably reliable. Here are 2 examples of the eyes that cause the superior arcuate field defect. Look at the amount of eyelash mascara that she has put in the top picture. And that lid is so heavy, it's blocking the visual field. And then this poor young Oriental guy who has an Oriental fold with eyelashes is causing a visual field defect. And then look at this hairdo. This person comes in with this hairdo, and I don't realize that this is a problem until she tells me. She can't reach the forehead bar because this hairdo is coming in the way. So no wonder she has got a ring scotoma. So these are obvious causes. That's why I don't let the patient go for visual field until I've seen the patient. So there are some visual fields that allow you to be able to detect whether this glaucoma is normal pressure or high pressure or both. Don't forget that normal pressure glaucoma patients can develop high pressure glaucoma. And then patients will say, then it's not a normal pressure glaucoma. No. Underlying the glaucoma is normal pressure, but they develop narrow angles because of the growth of their cataract. And then they get spikes of pressure. And then they get high pressures. So their glaucoma changes. And so you can see in this example, there is an inferior paracentral field defect. That's from the normal pressure glaucoma. And then there is another field defect in the nasal step inferiorly. That's from the high pressure glaucoma. So you can make out what kinds of glaucoma is going on by just looking at the visual field. Then you can make out this paracentral scotoma is of which kind of patient. This is not normal tension glaucoma. This is a high myopia patient. How do you know? Look at the blind spot. It is bigger than normal. And then this kind of scotoma is very unusual, inferior arcuate. I put this case up only to highlight the fact that we are doing a 24-2 visual field, only 24 degrees. There is 30 degrees, there is 60 degrees, there is 90 degrees. We are not measuring any of that. So we are not seeing the tail end of this scotoma because we are measuring the 24 degrees of area. So if you see this patient, how it progressed over time, you can see it became the inferior arcuate. It came closer to fixation. You see this. The top picture is the textbook picture of the what is called cloverleaf, okay? The bottom picture is the real world cloverleaf. You don't see that dark cloverleaf pattern in the top. What you see is this very irregular type of scotoma, and you can see that it shows 40% false negatives. This is an example of the modern day rim defect or ring scotoma. You can see it's all in the periphery. It's just the patient leaned back and now got the edge of the rim. And this patient wanted to have revenge against you. You can see that the patient kept pressing the buzzer all the time. And we have to make sure they don't have a gun because they're what we call trigger happy. You can see what you can see even without looking at all the reliability parameters is that the total deviation is normal and the pattern standard deviation is completely abnormal, which is never the case. Always total is greater or same as pattern. And then if the patient has 15 out of 15 fixation losses, I need to know from the technician, was the patient looking around? Or were you sleeping and the patient was sleeping? Both were sleeping in the dark room. So the technician knows that at the end of the visual field result, I am going to question them. Why did this patient have fixation losses? And so they put the note, monitored the fixation. Patient did not look around. Machine couldn't find the blind spot properly. Okay, so here is where the interactive starts. Tell me what's going on here. Somebody's saying, yes, please speak up. The blind spot is fallen down. How did this happen? No, it's not the position. Position was perfect. So, in the test, to test foveal threshold, the patient is supposed to look down into a yellow diamond. And then the machine tests the foveal threshold. After that testing is over, the patient is supposed to look up at the central fixation. If the technician did not tell them to look now up after foveal threshold testing, the blind spot will fall down. So it doesn't matter in a visual field that is near normal, but it does matter if the patient has a scotoma like this, and you can see what happens where the blind spot falls down and then the whole scotoma moves down. So it looks like this patient got a new inferior paracentral defect and therefore we should do something about it. No, just tell the technician, remind the patient to look straight. How many of you have done a visual field test yourself? Wonderful. I encourage everyone to do once, and then you will know what our patients are going through. This example of a visual field was done, which I felt that the technician was doing me a favor to add to my slide collection. I was like, how can you do this? Look at this test. Number of fixation losses, 21 out of 22. Full threshold instead of CETA fast. Okay? No ad for the patient's pseudophakic state. Age 13, patient is 83. She entered a wrong digit in the year of birth. Now, we don't pay attention to these things. We need to. We need to look at these because this is what it shows. And okay, 10-2, okay? Baseline. Next 10-2, this. The reason? Red stimulus. So red stimulus, because somebody previous to this patient did a plaquenil toxicity testing. And then here is an example of what is visual field progression. You can see visual field progression, right? A technician, my fellow says, yes, doc, we need to operate. Patient is really getting worse. You can see it. It's definite. Really? No. Look at the ad. Patient is pseudophakic. Finally, the technician listened to me and put the correct ad. Without the correct ad, you're not going to get a proper visual field test. Now, sometimes from the visual field, you can make out the diagnosis of the patient, like I told you about the type of glaucoma. So this is a case of optic nerve head drusen, right? You can see it. But sometimes the drusen are buried, so you can't see it until you do ultrasound or CT scan or something like that. But from the visual field test, you can make out this is a disc drusen case. How do you do that? You see, this visual field scotoma's inferior arcuate starts outside the blind spot and comes like this. All glaucomas start inside the blind spot or inferior to the blind spot. Only in disc drusen do you get an outside start of this. This is something I've noticed. This is something that is very helpful for detecting buried disc drusen. Monocular patient like this, you know what to do, right? Yeah, neuroimaging, correct? Then there is some example like this. Also, you can see that there is a vertical cutoff. Even if you don't have the other eye, you know this patient requires neuroimaging. And then this is a very classic case. So this is a patient with glaucoma who is one-eyed, okay? This is a very interesting case. One-eyed patient who seems to be getting slowly worse. He is not very compliant. He is in his mid-50s. This is his only seeing eye. So the other eye was lost to endophthalmitis following a trabeculectomy. So we are very hesitant to do anything because of that history. But you can see that he is progressing. So we talk to him about compliance and so forth and show him the visual field results. So we have two monitors in our rooms. One monitor is for all the documentation and the other monitor is for all the imaging. And that imaging monitor, we turn towards the patient to show them, this is your visual field, this is how much you didn't see, this is how much you're not seeing now. So they get convinced. OCT also we show them. We show them this red arc that is there, see your line dipped into the red and so forth. So they understand that. But then he comes back, despite talking to him about compliance, and now his visual field is even worse. And now you can see the slope was going like this and then suddenly it's getting much worse. So my fellow says, yes, let's do a tube surgery. We have talked to him about the tube surgery. He's willing, let's do tube surgery. And I'm looking at that visual field and saying, no. Tell me why no. Sorry? There is a midline defect? No, there is no midline defect. So here what happened is that, first of all, you don't go from a non-absolute scotoma to an absolute scotoma in glaucoma. Okay, you suddenly don't become absolute and stop here, like what you were pointing out too. It is not stopping at the midline, but it is a stoppage here, and then it doesn't trace here. This has suddenly become an absolute scotoma. I've blown it up here. I hope you're able to see. You see these numbers? minus 30, minus 28, minus 23, minus 21. Okay? This is not glaucoma. Suddenly, for minus 12, minus 10 to go to minus 30, and all along that vertical line, like you were pointing out, this patient was sent to neuroimaging. And neuroimaging is like, why are you sending us this patient? There's nothing wrong with this patient. It's like, no, there is an absolute scotoma that this patient has developed. I need to see why, because I don't have the other eye. And it turned out that he had glioblastoma multiforme in the brain, a brain tumor that was causing this. So this patient didn't need a trabeculectomy or a tube, but needed more important. So there are some rules that you have to follow or look for when you see a sudden change in the visual field. Okay. Can you tell me what's wrong with this visual field? This is a patient, again, who is not compliant, who comes back, and suddenly there's a drop. I sent this patient to neuro-ophthalmology. Neuro-ophthalmology refused to see the patient because they said, this is glaucoma. Why are you sending me unnecessary patients? Is this glaucoma? That is my question to you. Of course, if I'm asking, it's not, right? But are you able to see the problem? Are you able to see that this is a bitemporal hemianopia? This is the start of a bitemporal hemianopia. You see this loss, how it stops here at the vertical midline? You see this? There is a superior arcuate, but there is a vertical cutoff. So I said, it looks like, but I'm not sure. So I did an OCT. And the OCT gave me the final answer. And what is the final answer? Here. You can see the loss in the papillomacular bundle. See the difference? You can see the loss right here in the middle, in the papillomacular bundle. That confirmed for me, and sure enough, he had a massive pituitary tumor. Unfortunately, by the time neuro-ophthalmology saw this patient, he had a complete bitemporal hemianopia, complete visual field loss. And I then bypassed neuro-ophthalmology. I said, go to neurosurgery, get imaging done. And sure, when he got the imaging done, they took him for surgery. He recovered most of his visual field defect. But what is surprising is the nerve fiber layer thickness, ganglion cell thickness kept decreasing for another 6 months, despite having had surgery done. So this is something that is not known in literature, that the thickness loss continues even after resection of brain tumors, though the brain tumor is not recurring. Okay, this one, shall I send to neuro-ophthalmology? Or no? Patient has got an absolute new scotoma. Okay? It's a significant change, right, on the visual field? And it's an inferior arcuate and an inferior temporal loss. So could this be a CVA, a stroke, or something that can cause this, right? But no, you haven't seen the other eye of this patient. That's the other eye of the patient. Now can you tell me what has happened? Please speak up. It's okay. The technician did the right eye and told the machine that it is doing the left eye. Okay? So the machine thought this is the left eye and compared this visual field to the previous left eye visual fields. Whereas what is happening is you're just seeing the visual field defect of the right eye superimposed on the left eye. So this can happen because the technician just patches or covers the wrong eye. This case foxed me completely. This is a patient whose visual field definitely did get worse. I looked at all the parameters, age, refraction, zeta fast, fixation losses, everything. Everything was same, correct. And I'm like, yeah, your glaucoma does seem to be getting worse. But my rule is, if anytime somebody's glaucoma is getting worse, just repeat the visual field. So I call this patient and say, I'm not wanting to proceed with any major intervention until I confirm that this visual field is correct. And then she asked me the $1 million question. So this time, should I do it with my contact lens or without my contact lens? So this one was done with her contact lens. This one was done without her contact lens. The technician did not know that the previous time the patient had a contact lens in, so therefore put the same ad, and therefore we got an incorrect result. And this patient, of course, is doing fine 10 years later. And then there are some field defects like this that are atypical, but you look at the nerve, and the nerve doesn't match the field defect. So then you do have to do other imaging, and you realize that tractional changes on the retina, which you probably will see a lot because of tractional retinal detachments from diabetic retinopathy, will cause field defects like this. Or this case, who developed a field defect like this. OCT is abnormal, patient has glaucoma, but OCT is not changing. What is this? And I'm telling you, this is not a maculopathology. It's an occipital lobe infarct. Okay? It's an occipital lobe infarct. You can see how it's stopping at the midline, right there. And then this case, who has glaucoma, pressure of 24, mild glaucoma, comes to me for phacomorphic cataract removal. Okay? Because she has narrow angles. I've done a laser iridotomy 10, 15 years ago. Now she's like, they're saying, oh, you're getting visual field defects. You should undergo cataract surgery to relieve your phacomorphic element of your glaucoma. And this is the visual field I get. Okay. Last chance to tell me what it is. Okay? You don't get visual field defects with glaucoma right here, right? That is unusual. This is plaquenil toxicity. Patient is on hydroxychloroquine for rheumatoid arthritis, and therefore has developed now definite plaquenil toxicity. You can see the severe loss of the cones and the EZ-IZ junction. Okay, last two cases I'll share with you. This is a patient of, this is just harking back on yesterday's topic on normal tension glaucoma. This patient's pressure is always 10 to 12. He's got progressing visual field loss. Now, we are done with masqueraders, okay? This is real visual field loss. Patient is getting worse. Patient has got inferior field defects. Patient is only 60 years of age. If this patient's field defects, especially in the left eye, come close to the center, he'll lose the ability to read, even in that eye. He's already lost it in the one eye. So he's not convinced that he has glaucoma because his pressure is always 10 to 12. Everybody's telling him, what? You don't have glaucoma, your pressure is 10. So we send him home with a home tonometer. The eye care makes a home tonometer. Now the eye care 2 is a very easy instrument to use. So we send him home with a home tonometer, and this is the fluctuation we get. He immediately agrees for a trabeculectomy. We do a trabeculectomy, and 6 months later, we do the diurnal curve, and you can see it is much flatter. This is the opposite example. This is a patient whose visual field got worse, but the diurnal curve had a standard deviation of only 1.3. It wasn't very high. So I decided not to do a surgery on this patient. I send the patient to another doctor, and the other doctor says, you know what, I'm seeing a visually significant posterior capsule opacification. It's like, oh, I missed that. Because I'm focused on glaucoma, and I didn't see that posterior capsule opacification. It was there, right there in front of me. Called the patient back, did a YAG capsulotomy, and sure enough, the visual field improved. So, posterior capsule opacification, posterior subcapsular cataract will degrade the visual field. And that is something I'm sharing with you I missed. Learn from my mistakes. Thank you. Thank you very much.